Hello and welcome to the structure and function of the hematologic system. Here we're going to talk a little bit about what kind of things we could expect to see in the patient's hematologic system. That's the system of the blood. First of all, let's go through a little bit of review. Hopefully this will cover some of the stuff that you already looked at in your readings. So, which of the following proteins is not a normal component of plasma? All right, let's take a look at the answer. Collagen is not a normal component of plasma. So if you guess that one, you're doing well. Okay, let's take a look at number 2 then. What is the average lifespan of an erythrocyte? Erythrocytes are red blood cells. So what is the average lifespan of a red blood cell? And if you guessed 120 days, you are correct. So red blood cells will live for about 120 days, and then the body's going to destroy them. So the body's just going to decide that, hey, this red blood cell is getting kind of old. It can't do the same kind of function it could when it was younger. We need to get rid of it. We're going to recycle that heme and use it again to make new red blood cells, but this one's out of here. It's an old one, and we need to be able to have good, healthy red blood cells to carry the oxygen to the tissues of our body. Number 3, which of the following minerals is required for erythropoiesis? Yes, iron is required for erythropoiesis. It's a very important component of heme. So we need to have iron available. Now, it is important too that we have our other electrolytes available in the body in order for the patient to be able to develop good, strong cells and to have good, healthy function. But iron is a very important component of erythropoiesis and being able to produce new red blood cells. Erythropoietin, the hormone that regulates erythropoiesis, is released by the kidneys. So the kidneys are going to release erythropoietin, and that release is going to be regulated by ischemia at the tissue level. So hypoxia or ischemia at the tissue level, and we're just talking about very, very small amounts of hypoxia. So the patient doesn't have to be in shock or anything like that, but small amounts of hypoxia are going to stimulate the kidneys to release erythropoietin and for new red blood cells to be produced. The purpose of erythropoietin is now, hopefully this was a fairly easy one after what we just talked about, and hopefully you got that very easily. But erythropoietin does control erythrocyte red blood cell production. Where does sequestration and destruction of aged erythrocytes normally take place? The spleen. So the spleen is going to be the part of the body that is going to hold those old red blood cells and destroy them so that they are taken out of our circulation and new red blood cells are then going to be produced. As an individual ages, Letter B, lymphocyte function decreases. So the erythrocyte lifespan does not shorten as we age. Platelet numbers actually decrease. So those would not be correct. And its lymphocyte function decreases over time as a result of decreased a function of our immune system. When a blood cell is damaged, all of the above. Subendothelial collagen is exposed. Platelets are attracted to the collagen and platelets degranulate. So when a blood cell is damaged, the subendothelial collagen is exposed. The platelets are going to be attracted to that collagen. Platelets are going to degranulate. They're going to make that red blood cell become destroyed. It's going to be engulfed by the immune system. It's going to be destroyed, and it's going to be taken away and removed from the circulation. Red blood cell lysis yields which of the following products? Bilirubin. So hopefully you were able to get that one okay, right? So as we lyse the red blood cells and the red blood cells are broken down, we're going to have an increase in the amount of bilirubin that is released. And normally that is going to be handled by the liver with no problem, and we're not going to have a buildup of bilirubin in the body. But this is one of the ways that a patient ends up having jaundice when a patient has liver disease. Red blood cells are being destroyed, bilirubin is being released, and it's going to cause that yellowish discoloration of the skin as bilirubin starts to build up in the patient's body. Which is the correct sequence in coagulation? So the tissue is damaged first, factor 10 is released, fibrinogen is released, then we get prothrombin, and finally we get a clot. Which is the following sequence, or which is the correct sequence in fibrinolysis, the removal of blood clots? Plasmin, plasminogen, and then FDP, which is fibrin degradation products. Kind of interesting there that we have A, B, C, and then A again. Sorry about that. So our last A is supposed to be a D. Granulocytes contain enzymes capable of killing microorganisms. That's what our granulocytes are going to contain. Why do lymph nodes enlarge and become tender during an infection? Macrophages are proliferating in our lymph nodes, and that's what's making them swell and become tender. They become tender because they're swollen and they're taking up more space, and we're kind of stretching the outside of that lymph node, so that's why they become tender. Eosinophils. of the above can phagocytize, they can ingest antigen-antibody complexes, and can be induced to attack parasites. The greatest proportion of total body iron is located in the erythrocytes. The greatest proportion of our total body iron is located in the erythrocytes in form of heme, which forms the hemoglobin, the oxygen carrying capacity, or the oxygen carrying compound of the red blood cell. Let's take a look at our blood. So when we're taking a look at our total body weight and the total amount of fluids and so on we have in the body, we have about 92% of our overall weight being other fluids and tissue. Okay, so remember there, there's got to be some tissue in there too. But we have quite a bit of our body weight that's made up just by fluid. And then blood is still going to account for about 8% of our total body weight. Of that blood, we can separate the blood out, the whole blood. Okay, now so they see the picture there in the middle that has the test tube has got whole blood in it. Whole blood contains plasma and other formed elements. Now let's separate those out. The plasma part we can separate into proteins, water, and other solutes. The proteins are primarily albumin, but also globulins, fibrinogen, prothrombin, and then our other solutes, iron, nutrients, waste products, gases, and regulatory substances. Now let's move down to the bottom. The formed elements are going to be your cells. So platelets, leukocytes, and erythrocytes are going to make up the formed elements. So there's two major components of whole blood. Now, you may hear people talk in a hospital about giving a patient blood, and in many cases what we're giving is not whole blood to the patient. Instead, what we're giving is some of these components. For example, we may give what's called packed red cells. So we're giving erythrocytes to the patient instead of giving whole blood, so we're pulling out some of that plasma. Now, part of the reason for doing that would be if the patient has a low red blood cell count, we can give red blood cells to the patient without having to give the other stuff that's listed there. So go up the scale there into the plasma and look at, okay, maybe the patient doesn't need the proteins and the water. Okay, water may be a big problem if we gave the patient all that water that came with whole blood in order to try to get the red blood cells into the patient's body. So that could be kind of a problem for our patient. If we gave them all that additional water, we may fluid volume overload them. So that's why we may pick one of these components. We may be giving the patient just simply platelets and not giving the patient any of these other components, the formed elements, or those components of the plasma. Or we may say, hey, you know what, this patient's got a low albumin level, or the patient has problems with maintaining their intravascular volume. We're going to give the patient some albumin. Notice that's up at the top. They're under proteins. And we give the patient albumin to try to hold fluid into the patient's vasculature. So there's a number of ways that we can work with this in order to make sure that our patient is going to have an adequate amount of fluid volume that they're getting, and to make sure that we're not overloading somebody, but just giving them the nutrients and the products that they need. At the same time, too, it's helpful to look at the differences between whole blood plasma and our components so that we know what kind of stuff could potentially be a problem for our patient. What this diagram here is showing the effect of erythropoietin on our red blood cell production. So we have a decreased number of red blood cells in the bloodstream, and basically what we're going to find out, the way the body's going to assess this, is the body is going to assess the fact that there is hypoxia at the tissue level, which will then stimulate the kidneys to produce erythropoietin. Erythropoietin is going to stimulate both the production of more red blood cells and the release of red blood cells from the bone marrow into the bloodstream, and then we're going to increase our oxygen carrying capacity. Three main components of homeostasis. We have the vasculature, we have blood proteins, and we have platelets. So the endothelial cells in the vasculature, the blood proteins, clotting factors, and our platelets are all going to help us to be able to maintain homeostasis. Our injured tissue and activated platelets help to start this clotting cascade and the clotting mechanism that's going to help the patient to be able to clot and not to continue to bleed. Now remember that bleeding is going to be the natural result of having any kind of an injury or any stimulation of the inflammatory response. In inflammation, we have clotting as one of our characteristics, one of the pieces that happens. This is a compensatory mechanism that's perfectly normal, and it's very helpful to the patient because it's going to keep them from bleeding to death if they've got a cut or they've got an injury. The clotting cascade can be broken down into two different components. There's the extrinsic pathway and the intrinsic pathway. Now, the best way that I can describe this to you is to think about the extrinsic pathway as coming from damage outside and intrinsic as coming from damage inside. Now, we're not talking necessarily about outside and inside the body. We're talking about outside and inside of the blood vessel. Okay, so we have our blood vessels running throughout the body. If there's damage on the inside of the blood vessel, that can cause the intrinsic pathway to become activated. So when can we get damage to the inside of the blood vessel? Well, during atherosclerotic disease, we can. That would be something that only damages the inside of the blood vessel. Viral diseases, other kind of conditions like sepsis, can damage the inside of the blood vessel. The extrinsic pathway, on the other hand, is going to be activated when we have damage to the outside of the blood vessel. So maybe this is caused by trauma, maybe this is caused by surgery or some other event where we're damaging the outside of the blood vessel. What you're going to find in most cases is that we're going to have both of these things activated. So let's think about a situation where you may need to have clotting. You accidentally run into something and you get a cut on your arm. Now that cut has not only damaged the outside of the blood vessel, but it's also cut into blood vessels and damaged the inside of the blood vessel. So both pathways now are going to be activated, the intrinsic and the extrinsic pathways. The extrinsic pathway is going to activate tissue thromboplastin, which is going to activate our clotting cascade, whereas the intrinsic pathway is going to activate a cascade of clotting factors. The clotting cascade is actually very complicated. There's a couple things you do need to get out of the clotting cascade. One of the things that you need to get out of this clotting cascade is the fact that there's many different steps that are involved in the process. And calcium is important in this process in order for clotting to occur. So we have two different pathways. There's inside the blood vessel, outside the blood vessel. Either one of them can activate the clotting cascade. And calcium is very important. Now, another thing we can get out of looking at this picture is the fact that there's many different spots along this clotting cascade where maybe we could potentially block the blood clot. You see, because the blood clot doesn't happen until way down there at the bottom. So if we were able to block one of these things along the way, let's say that we blocked thrombin, that would keep the fibrinogen and fibrin from causing that clot to form. What if we blocked fibrin? What if we blocked activated factor X, factor 10? Okay, so you see there's a lot of different places we may be able to block this clotting cascade. And that's why you're going to find that there's different kinds of drugs out there that are used as anticoagulants, because there's different places in this clotting cascade that we can essentially block. So the cascades can be activated in two different ways, and we already mentioned these as far as the extrinsic or the intrinsic goes. All of those routes lead to the factor 10 and thrombin formation and then the eventual blood clot. So let's take a look at this in a little bit more detail here as far as the process that's occurring here when the patient has a clot forming. So up on the top here we have endothelial sloughing that is occurring as a result of having some kind of injury, and that's starting to activate our platelets and starting to fill in some of these gaps. Now, you don't need to know all of these different pieces, but it's good to start looking at some of the names and starting to become a little bit familiar with them. Thromboxane A2, inhibited by prostacycling. So it's important to start seeing these names, to start seeing these things, and start to gain a little bit of recognition. It's probably not going to all sink in at this point, but hopefully by the time you're done with nursing school, this is going to start to sink in a little bit better for you, and you're going to have a better idea as to what's going on with the whole inflammatory process. Inflammation is very complicated, so don't feel bad if you're looking at this going, oh my gosh, I can't even believe this. There's physicians that don't understand all of the clotting cascades. So it's a very difficult process that's occurring. When you look at some of these other things that are listed out here, one of the things I want to bring your attention to is under adhesion. It talks about GP 1A and 2A and GP 2B and 3A. There are drugs that we use that block GP, these are the glycoproteins, 2B and 3A, in order to try to prevent the patient from having clots form. And we can help to keep people from having clots forming in the body where it could cause them to develop thrombus in one of the vasculature, especially the cardiac vasculature. So we have the first part, the endothelial exposure, so the exposure of the inside lining of the blood vessel. Then we're starting to have adhesion. Adhesion means that we have these cells starting to kind of attach. So think about it like the subendothelial exposure is kind of like a rough spot on the inside of the blood vessel, and then our clotting mechanisms, our clotting factors start to adhere to that rough spot. Now we're starting to get activation of platelets, and we're going to talk about platelet activation in here in just a moment. But platelets, and maybe you can see it from the picture on the bottom, this is probably the best illustration I've seen so far, but when you take a look at the platelets, and let's look at them as they go all the way through here. So look at the picture at the top, and the platelets are illustrated there in blue. There's a round little blue things. Okay, as you go down into the second picture, you can see that a couple of those round little blue things are starting to grow what looks like legs. Now you get down to the bottom one, and you see a whole bunch of those little blue things looking like starfish. That's the difference between an unactivated platelet and an activated platelet. Platelets are normally round. They just flow right on through the circulation. See, and that's important because if they were activated all the time, if they look like the little starfish all the time, they'd constantly be forming clots, and we don't want that to happen. We want platelets to be there, but we don't want them to be forming clots where they're not supposed to. So we have to wait for something to activate the platelets, and that's what we're talking about here in step 3. We're talking about activating the platelets. The platelets become activated. They change their shape into those things that look like starfish. Now that's important because those little starfish looking things grab onto stuff and start forming the clot. So that's the first step in forming the clot. Then we get aggregation. So the platelets are starting to aggregate in the same process now. We're starting to also get some thrombin forming. So some of our clotting factors, thrombin, fibrin, etc., are starting to form around those platelets that are starting to stick together, red blood cells, etc., and we're forming a clot. So that's what forms our clot. We get a fibrin mesh there, etc., and that's forming our clot. Next we get the platelet plug formations. Now we have our red blood cells, our platelets, now they're all enmeshed in the fibrin, and we have a good clot here. So this is a clot that's going to keep the bleeding from occurring. Take a look at that mess inside that blood vessel. Okay, we've got a real mess going on inside that blood vessel. So if this was a process that was occurring as a result of a patient having atherosclerotic disease, that could really roughen up the inside lining of the blood vessel, causing more stuff like fatty tissue, etc., to stick to that thing, and could start to cause the patient to have a narrowing of the vessel. This is part of the process that occurs in atherosclerosis. Lastly, we have clot retraction and clot dissolution. Scar tissue and clots will retract. Now the purpose of doing this is that it's pulling those edges back together again. So think about having a cut on your hand. You get a cut on your hand, and maybe a week later you look at it and you got this big scab there, and maybe a month later you look at it and you're like, wow, there's a really big scar there from that cut that I got on my hand. And 2 months later or 6 months later, that scar starts getting smaller and smaller. Because over time what happens is that we get retraction in this process of healing. And the retraction is actually a contraction of those tissues, pulling them closer and closer together so that the scar becomes smaller and smaller and we don't have as big an open area. And hopefully what will eventually happen is that that clot is going to degrade and we'll have normal healthy tissue form in its place. So here are a couple platelets blown up extremely under a microscope, and you can see the green one there is just a mildly activated platelet, pretty round, but it's starting to have a couple of little appendages sticking out. Now notice that orange one there. The orange one has got all those appendages sticking out. So those little appendages are going to help it to stick to other platelets, and that's what's going to help to form the clot. Again, just another picture of how this might occur and the process that's occurring with the patient having clotting as a result of having an injury. So we have an injury here. The patient's got a cut on his foot. We have the extrinsic pathway. Since we damage the outside lining of the blood vessel, we have the intrinsic pathway. Since we damage the inside lining of the blood vessel, those are causing thrombin and prothrombin to help to form the clot. We have that clot forming the fibrin mesh, and now we have a clot, and we stop bleeding, and we can start healing. Normal destruction of old red blood cells occurs when they get old. I mean, 120 days is about all they can do, and then we got to get rid of those, and we got to get new ones in their place. So it's not a matter of just having red blood cells produced once, and then they're produced and they stay there forever. Now, the advantage to turning over our red blood cells is too that if we happen to have an episode of bleeding, so you cut yourself and maybe you have some significant bleeding from that cut, you're going to produce more red blood cells. So that's a good process that we know we're going to be producing more just in case we do happen to run into a situation where we have a significant amount of bleeding. So our old red blood cells are going to be destroyed. They're going to be sequestered. And they're going to be destroyed in the spleen and in the liver if the patient's had their spleen removed. But typically it's going to be in the spleen. And then it's broken down into amino acids. That's going to be part of the red blood cell. And then reduced to bilirubin, which will then be secreted by the liver as bile. However, remember again that if the patient has liver disease, that bilirubin can start to build up. The patient can start to develop jaundice, and that's where we see that coming from. Aging red blood cells are replaced slowly. We have iron depletion occurring, and that makes them less functional. There's a red blood cell here being engulfed by a macrophage, so it's kind of showing a time-lapse photography here. But the big thing marked by the M is the macrophage. The little thing marked by the R is going to be the red blood cell, and the red blood cell is engulfed by the macrophage. Macrophages are white blood cells in the body. They run around and they destroy the tissues that need to be removed from the body. So in this case here, we're talking about a red blood cell that needs to be removed from the body because it's old and it needs to be replaced. Anemia is a situation where a patient has a decrease in their number of red blood cells, and that can be caused by a variety of different things. Three of the main causes that are going to be potentials for anemia are that the patient has an iron deficiency, the patient has a blood loss, or thirdly, the patient has some kind of chronic disease state, and that chronic disease state is causing them to either produce fewer red blood cells or destroy their red blood cells quicker. So in order to be able to figure out which one of these things is the problem and the cause for our patient's anemia, we're going to need to look at a couple different things. We're going to need to look at the size of the red blood cell and the amount of hemoglobin content. We can classify these things by talking about the size in terms of cytic. So we can talk about a macrocytic red blood cell, a microcytic red blood cell, or a normocytic red blood cell. Macrocytic means the size of the cell is too big. Microcytic means it's too small. And then normocytic means it's just the right size. That's a normal size red blood cell. All right, well, what's causing the change in the size of the cell? This changes in the size of the cell is going to be caused by how much protein is inside that red blood cell. So a macrocytic cell is going to take on too much protein, usually because there's not enough hemoglobin in that red blood cell. Microcytic, not enough proteins. Maybe the patient has a malnutrition kind of situation, so there's not enough protein to be able to bring into the red blood cell to make it large enough to make it a normal size cell. Then we have our normocytic cell. It's a normal looking, normal size cell. Next, we can talk about the amount of hemoglobin content the red blood cell has. So again, what they're going to do is they're looking at these things under a microscope. And in the microscope, they're able to tell what the size of the red blood cell is and what the hemoglobin content is by the color of that red blood cell. So we can talk about the hemoglobin content in terms of chromic, meaning the amount of color that the red blood cell has. So we have a normal chromic type of cell, which means that it's got the normal color that it's supposed to have, or a hypochromic. It doesn't have enough hemoglobin and it doesn't have enough color to the red blood cell. So what we're looking for is normochromic, normocytic red blood cells. That would be a normal red blood cell. Symptoms of anemia are based on severity and compensation. So you can have a mild anemia and have no symptoms. The other part of this is the compensation part. If you've had anemia for a number of years, your body will compensate for that anemia and you won't feel the same kind of symptoms as if it were acute. The classic symptoms are going to be fatigue, weakness, dyspnea, pallor. Pallor is a paleness of the skin. And so those are going to be our classic symptoms. And again, the faster this happens, so for example from blood loss, the more likely it is that your patient is going to have some symptoms. If it's a longer period of time this has been going on, you may not see the symptoms generated in your patient. What this very busy diagram is showing us is the function by which the patient is producing red blood cells and how having anemia is going to affect the patient. Well, one of the first things it's going to do as you go down your chart here is to cause tissue hypoxia. So you can see that can cause ischemia, which could actually lead to myocardial infarctions and things like that. On the other side, we're going to see symptoms such as an increase in respiratory rate and depth, etc., because the patient's breathing faster, trying to get more oxygen in the lungs so that we can get more oxygen to the tissues, because we're going to have tissue hypoxia if there's not enough red blood cells to carry the oxygen to the tissues. Compensatory mechanisms will include some cardiac compensation from the standpoint of the heart working harder, trying to get more oxygen to the tissues of the body. Now, if the heart's already compromised in some way, that could really be a problem. That could really lead to the patient developing things like angina and other kinds of cardiac problems. So that could really be a problem for a patient. On the other hand, we're also going to have additional compensation, such as renal compensation, increase in the renin-angiotensin response, and also an increase in the amount of DPG. If you look all the way over on the right-hand side, increase in DPG in cells. DPG is diphosphoglycerate. This is a chemical. This is a substance that is necessary in our red blood cells to bind oxygen to hemoglobin. So this is a necessary compound in your red blood cells in order to be able to bind oxygen to hemoglobin. So very important component that we have there in order to be able to do that binding process. Okay. So you might want to just pause on that previous slide there for a few moments and take a look at it and make sure that you understand, or you have an idea at least, of what those different sprouts of that diagram are showing. So anemia can be broken down into a few different classifications here. We can have macrocytic normochromic. Okay, so this means we have a big cell, but it has the normal amount of hemoglobin in it. It has a normal amount of color. So this is called megaloblastic anemia. This is a pernicious anemia. It's also from a folate deficiency. Microcytic hypochromic anemia. This is the kind of situation that occurs. We have small cells that don't contain enough hemoglobin, so they're small, they're light in color, and this is an iron deficiency kind of situation. The third type is a normocytic, normochromic type of anemia, and really the most common reason for this is going to be blood loss. So it lists out some other things here like hemolytic anemias and sickle cell anemia, etc. But the most common cause for a normocytic, normochromic anemia is going to be blood loss. All right, so why do you need to know this stuff? Well, if we look at our red blood cell differential, it can help us to be able to determine which of these types of anemia the patient has, which would be very important so that we know what kind of teaching the patient needs. If the patient has a microcytic hypochromic anemia, they're going to need some teaching about a diet that's high in iron in food. Okay, if the patient has a normocytic, normochromic type of anemia, then we'd anticipate the patient's probably going to receive blood and may need some teaching about that, and we can start preparing in order to be able to transfuse the patient. The macrocytic, normochromic types of anemia, these are anemias that usually come from chronic disease states. The physiologic response to anemia, remember that there's less oxygen carrying capacity of the blood, so therefore that means there's going to be less oxygen getting to the tissues and we get tissue hypoxia. So our compensatory mechanisms are going to be an increase in our plasma volume, Okay, and that's coming from the renin-angiotensin-aldosterone system. Thinner blood, because we're hanging on to more fluid in an attempt to try and increase our blood pressure, assuming that that's what the problem is a lack of pressure in the vasculature, and that's why we have decreased perfusion. We'll have an increase in our blood flow caused by an increase in heart rate and stroke volume. And I remember again from your hemodynamics that stroke volume is the volume of blood pumped out of the heart when the heart contracts. We can have cardiac and pulmonary symptoms as both the cardiac system and the pulmonary system start to try to compensate and get more oxygen to the tissues of the body. Increased rate and depth of breathing, shortness of breath, and dizziness can all be compensatory mechanisms as a result of the patient having tissue hypoxia caused by not enough circulating red blood cells to carry oxygen to the tissues of the body. Iron deficiency anemia, although it's the most common form of anemia, keep in mind too that anemia can also be a situation where we have from blood loss. So anemia can also be caused from blood loss as well. So just keep that in mind that blood loss may be another very common form of having a low red blood count and having anemia. So in our patients that you're taking care of in the hospital, you may have to say, look, I think this is probably not iron deficiency because that's the most common form. So iron deficiency is the most common form of anemia, having that's not associated with bleeding. So who then is going to be at risk for having iron deficiency anemia? Well, people who have a diet that is not rich in iron are going to be at risk. So people who are living in poverty, women of childbearing age, children may not be taking in enough iron in their diet. So we're looking for poor dietary conditions, malnutrition. Those are going to be situations where the patient may develop an iron deficiency. So look at the patient's diet. That's going to be one of the first things that's going to give us a clue. Bleeding that results in iron loss. Okay, so some kind of chronic bleeding like peptic ulcers, etc., can cause the patient to lose iron, where now we don't have enough iron to make new red blood cells. This gets into kind of a sticky situation here. What came first, kind of the chicken or the egg thing, right? So is it the bleeding that is causing the anemia, or is it the bleeding causing an iron loss, an iron deficiency, and then the patient's having a secondary iron deficiency anemia? So this could be kind of a difficult situation in order to figure out. Probably what they're going to do to treat this anyway is going to be to give the patient blood. Beyond that, they may also have to give the patient some kind of iron replacement or change the patient's diet in order to make sure that there's a sufficient amount of iron in the diet. Another situation that ends up in causing anemia or a decrease in a red blood cell count is sickle cell anemia. And sickle cell anemia is a situation, it's an inherited condition, because it's autosomal recessive, and it's an inherited condition, more common in the United States, it's more common in African Americans. Worldwide, it's more common in the Mediterranean, South American populations. Indian population seems to have a natural protection. Two major forms. There's sickle cell trait, there's sickle cell anemia. Sickle cell trait means the patient has one defective gene, so they're just a carrier. So they're carrying the trait on that they could pass it on to somebody else. Somebody has both defective genes, then they're going to have sickle cell disease. So we're kind of defining it as being the trait, just carrier basically, or having the disease itself. Now the disease, sickle cell disease, can cause the patient to develop a sickle cell crisis. When sickle cell crisis occurs, what happens is that the red blood cell is going to change its shape. And it changes its shape because hemoglobin lines up in a straight line. So as that red blood cell is exposed to hypoxia, hypoxia is the most common cause for somebody to develop a sickle cell crisis. So as that red blood cell is exposed to hypoxia, the hemoglobin lines up in a straight line. And that changes the size and it changes the shape of that red blood cell. So we started off with having a red blood cell here nice and round and easy to kind of get through the vasculature, and now we have something that looks like this moon shape here, and it becomes stiff, and it's much harder to get that thing through the vasculature. Now, if we treat this at this point in time, and we get the patient some oxygen. Okay, you see hypoxia is the thing causing the problem. So give the patient some oxygen at this point. We can reverse the process and the red blood cell will go back to being a nice round red blood cell carrying oxygen, etc. If we do not get the patient oxygen soon enough, then the hemoglobin not only lines up in a straight line, but it binds together. And then this change in cell shape becomes permanent. And then the body has to destroy those red blood cells and get rid of them. Okay, now understand the underlying problem going on here is that the patient has sickle cell disease. So they have this hereditary disease that results in them having a specific kind of hemoglobin called hemoglobin S. Here are some of the situations that can cause a person to develop a sickle cell crisis. So you can see there's quite a few etiologies that can cause sickle cell crisis. And we're looking at some of the cells here. You can see some of the normal red blood cells, nice round red blood cells. And you see some cells that are very deformed. They're maybe very straight in nature. One of them up toward the upper right corner has a very sickled shape to it. And those red blood cells are not going to pass through the vasculature as well as they probably should. Now, the normal presentation is that a patient is going to go through these processes here of having a bone crisis. Acute chest syndrome might be another process. Let's just back up for a minute and talk about what those are. Bone crisis and joint crisis mean that the patient is having pain in the bones and the joints. The reason why the patient's having this pain is because these sickled cells are getting stuck in the small capillaries and blocking perfusion through those small capillaries, and then that's causing ischemia and then pain. The patient may also present having abdominal pain. That's called an abdominal crisis, or the patient may present with what's called an acute chest syndrome. In this situation, what happens is that the patient develops chest pain and is presenting with having that chest pain. Now, in this animation, it's going to show the process by which we have our sickled cells. So the patient has that hemoglobin S, and that hemoglobin S then is going to start to become distorted by a hypoxic situation, and then those cells are going to get stuck in the circulation. So again, more common in African Americans and some of the other populations listed here. Now here's our normal red blood cells going through the vasculature, and you see how they're just flowing very nicely through that vessel. They kind of squeeze through that capillary network. However, in sickle cell crisis, what happens is the cell changes its size and shape. Notice it's very concave now. It's very sickle shaped, and those sickled cells don't adapt. They don't squeeze through that capillary network. Instead, they get stuck, and they're going to block that capillary, and they're going to cause the patient to have a significant amount of pain from ischemia downstream of that sickled cell. Some other types of anemia that we have to deal with include a pernicious anemia, and pernicious anemia is a very common type of macrocytic. Now remember, macrocytic is the big cell type of anemia. This is caused by a vitamin B12 deficiency and an underlying absence of an intrinsic factor that's necessary for the production of our red blood cells. It can be an autoimmune disease, can be congenital. In an autoimmune situation, that means the body is attacking our the ability to be able to make B12 and to be able to use B12 to make our red blood cells. Bariatric patients may be at risk because of gastrectomy and removal of the parietal cells. Hemolytic anemia is another type that, in this situation, what's happening is that the patient is actually destroying their own red blood cells. There's a hemolysis of the red blood cells. They're destroying their own red blood cells. And this could be caused by an infection, some kind of systemic disease, a toxin, or it could be maybe hepatomegaly. So the end result is we're going to have hepatomegaly as a result of having these red blood cells being destroyed and starting to collect in the spleen and the liver. But in hemolytic anemia, we have some kind of process that's causing red blood cells to be destroyed. Could be autoimmune or could be an infectious process, but it's causing our red blood cells to become destroyed. Now, on the other hand, we can also have a proliferative kind of red blood cell disorder, in which case we have too many red blood cells. So there's a relative polycythemia, which occurs when we have dehydration or blood loss. In other words, we have the same number of red blood cells, we just don't have enough water to dilute them in. So if you go back to that picture we started with, when we had the picture there of the whole blood and how much of that whole blood was plasma, how much of that was water. So you take that water away, and now we're going to have very thick, viscous kind of blood, and that's going to lead to a possibility of having thrombi occur because it's slow and sluggish and it's going to get stuck in the circulation. On the other hand, we can also have an absolute or a secondary type of polycythemia where we have an increase in the amount of red blood cells that are being produced. This can happen for two different reasons. Chronic hypoxia, so your patient's chronically exposed to hypoxia, which is chronically stimulating them to produce more red blood cells, or it can be the result of having an erythropoietin secreting tumor. So there may be a tumor on the kidney that's secreting erythropoietin, causing too many red blood cells to be produced. White blood cells, on the other hand, we can have the same situation. We can have too many or too few. Normally, a leukocytosis, too many, is going to be a normal protective response when the patient has an infection or inflammation. So we're going to see an increase in our white blood cell count as a result of having inflammation or infection. On the other hand, we can have a leukopenia, a decrease in our white blood cell count as a result of the patient having some kind of disease process. Granulocytes are another part of our immune response, and we can see a decrease in our immune response or a decrease in our granulocytes when the patient has an immune mechanism or response or chemotherapy or radiation that's destroying those granulocytes. On the other hand, we can see an increase in the amount of granulocytes we have in the beginning parts of infection or inflammation. Neutropenia, another type of the neutrophils, another type of white blood cell, can also be decreased in situations where the patient has a chronic infection and we're chronically kind of using up those neutrophils. Here's our normal white count here, and one of the terms that you're going to hear referred to when you get into the clinical area is going to be this shift to the left. And what we're referring to with a shift to the left is we're referring to the mechanism of the numbers of different types of the differential of our white blood cells. So if we were to differentiate out our white blood cells here, we see that bands are responsible for just a very small amount of our white blood cells. Bands, by the way, are immature cells. Then we have our neutrophils, and we have our lymphocytes, our monocytes, etc. So these are the different types of white blood cells we have. Now, in an infectious situation or a severe inflammation, what's going to happen is that we're going to see some elevation in our white blood cell count, and that's going to be primarily the result of certain white blood cells increasing. And we call this thing a shift to the left. Now, if you're looking at these components on a diagram like this, it makes a lot of sense. If you're looking at them on your typical lab results, where everything is listed from top to bottom, then it doesn't make a lot of sense as to what shift to the left means. But what they used to do years ago is somebody would sit down at the microscope and they would look at this stuff and they would write these things out from left to right, and that's where we got the term shift to the left. Okay, now here's a patient who has an infection. Notice that these numbers have shifted to the left. In other words, there's more bands, there's more neutrophils, there's fewer lymphocytes. Okay, so that's the thing we're looking for there. There's fewer lymphocytes and there's going to be more of our neutrophils and bands. That's the shift that we're looking for to the left. Leukemia is a situation where the patient has an excessive production of immature white blood cells. So we're overproducing our immature white blood cells. And this is going to be a problem because those immature white blood cells will start to crowd out the mature white blood cells. We're going to distinguish what type of leukemia we have based on a couple things. First of all, the cell of origin, whether it's myeloid or it's lymphoid, and also on whether it's an acute or a chronic type of leukemia. In an acute leukemia, we have a situation where this is happening very rapidly and very quickly. That's one of the things we normally think about with an acute leukemia, is that the onset was very rapid rather than being very gradual. We can break it down into two different types: lymphocytic leukemia or myelogenous leukemia. So lymphocytic is going to be least common type overall. It is common in children, though, or it's more common in children than would be the myelogenic leukemia, more common in adults. Very low survival rate of AML. Chronic leukemia, on the other hand, is a slow process where we're getting more undifferentiated or more less and less mature cells, so more undifferentiated, more immature cells over a longer period of time. So longer survival time in chronic leukemia than we have in a acute leukemia. Again, we can break that down into a couple different types. We can call it lymphocytic leukemia. We can call it myelogenic leukemia. Mostly adults in the CML version, mostly children in the lymphocytic. So you see, lymphocytic leukemias are going to be more commonly occurring in children than the myelogenous type of leukemia. Pretty good survival rates, though, with chronic leukemias. Now, with this diagram here, this very busy diagram, and you might want to pause your video at this point and kind of look on down through it, but it's showing how our cells differentiate. So we have the acute undifferentiated leukemia and the end results of what's going to happen as a result of that undifferentiated leukemia as far as the rest of our immune system goes. Okay, so what on earth causes somebody to overproduce immature white blood cells? Well, it can be a few things. There can be a genetic aberration, and one of the most common reasons why would be the Philadelphia chromosome. And Philadelphia chromosome is the result of a translocation. We'll take a look at that in a moment. Errors in protein metabolism could also cause a genetic aberration. It could be a hereditary tendency toward having leukemia. Remember, we talked about Down syndrome and the possibility of an increase in leukemia in that patient population. Of course, the environment may also play a factor, so it may be multifactorial as far as what is actually causing the person to develop leukemia. Here's the Philadelphia translocation, and basically, again, all we're having a translocation of our normal chromosomes, which results then in having an immature white blood cell being produced that is not able to mature and differentiate into normal white blood cells, and then it's going to not be able to fight infection like we'd hope that it normally should. Lymphocytes are another type of our white blood cell, and we can see an increase in the number of lymphocytes we have with acute viral infections. We can see a decrease in our lymphocyte count with immune deficiencies and with viral destructions of our lymphocytes. There can be malignant lymphomas like non-Hodgkin's and Hodgkin's lymphomas that are causing a malignant destruction of our lymphocytes in our lymph system. So here's a picture here of lymphocytes and macrophages, and just to give you an idea, the macrophage still being the bigger of the cells there, and then the lymphocytes in between are marked with the letter L. Non-Hodgkin's lymphoma is a diverse group of lymphomas, and basically what we have going on here is we have a neoplasm of the lymphatic system. Now keep in mind, the lymphatic system is the system that drains wastes from the body. So having a neoplasm in that lymphatic system is going to block up the lymphatic system and potentially cause the patient to have kind of chronic low-level inflammation or infections all the time. So we tend to get fever, night sweats, weight loss, things like that as a result of non-Hodgkin's lymphoma. Multiple myeloma, on the other hand, is a B cell type of cancer. What's happening here is we have plasma cells that are blocking up the bone marrow. So plasma cells are precursors to B cells, and they're being overproduced, and they're blocking up the bone marrow. And oftentimes what we'll see is a lot of bone pain, possibly pathologic fractures as a result of multiple myeloma. This is a picture here of lymphadenopathy, and where you can see it primarily in this patient is look up toward his face, up in his neck there, up toward his face, and you can see some very swollen glands under his chin. Also down in the groin area and under the axilla, you can see some very swollen glands. Okay, now most people don't get lymphadenopathy this badly, but this is a very extreme example of what it might look like in very, very swollen lymph glands. This is a gentleman here who has acute lymphocytic leukemia. The spleen, remember, has a couple different functions. One is it's part of the immune system, so it helps to filter out some of those bad things that are rolling around in the body. But the second function of the spleen is to get rid of those old red blood cells. So splenic disorders can really be a problem for the patient's body. So splenomegaly is a situation where we have an inflammation or a swelling occurring of the spleen as a result of having either overactive splenic function or having some kind of underlying disease process that's starting to block it up. So inflammation, infection, congestive disorders, things like that. But we're starting to see our red blood cells, white blood cells, etc., starting to sequester in the spleen and making it swell. Here's a bunch of red blood cells that are kind of squeezing through the sinuses and the spleen. So this would be a normal function as they're squeezing through the sinuses. Think of the sinuses and the spleen as being like a filter, and we're filtering the blood, where the red blood cells are able to squeeze on through there and move back through the rest of the circulation. Platelet disorders, there's a couple kinds that we can see. The primary platelet disorder you're going to see in patients that you're caring for is going to be just a low platelet count. So the patient's going to end up having a low platelet count as a result of, and that's called a thrombocytopenia, and that's going to be the result of just losing platelets because of whatever their underlying disease condition is. So the patient had surgery. They used a whole bunch of platelets to try and clot up that area where the surgery was, and now the patient's got this platelet, this low platelet count. So they just used up the platelets they have. So that's what we're going to see in most situations of decreased platelet counts. However, there are some drugs that can contribute to the patient having a low platelet count. One of the most common ones is heparin, and it's called a heparin-induced thrombocytopenia, where the heparin is causing an immune complex to destroy platelets. Other kind of systemic conditions, because they're altering the normal physiology of the blood, can make it uncomfortable for platelets to live, decrease their lifespan, and then therefore decrease the amount of platelets that are in the body, like chronic renal disease, liver disease, etc. There can also be disease conditions that can cause a patient to have an altered platelet function. They've got a normal amount of platelets, but the platelets they have are not functioning well. So we can have some kind of immune diseases that cause that situation to occur too. Primary thrombocytopenia is when we have a platelet count less than 600,000. Usually, again, this is going to be the result of just the patient using them up, microvascular thromboses. In other words, we're just using up our platelets to try and clot off that area where the patient had surgery. A thrombocytopenia, now we have platelet count less than 150. We're going to start to be concerned when that platelet count hits 50. Now we can start to see some bleeding occurring in our patient. With a platelet count less than 10, we have to really, really be concerned. The patient can then develop spontaneous bleeding. Now keep in mind that this is very dependent upon the kind of patient and the situation you're in. If you're caring for patients on a cancer floor, those patients run around having platelet counts of 10, 11, 12 all the time, and they're not having a bleeding risk. They may have some bruising issues, but they're not having a lot of uncontrolled bleeding, like bleeding in the brain and things like that. Okay, so just keep in mind your patient population. However, if you or I were to develop a platelet count of 10, we would probably just start spontaneously bleeding from parts of our body. This is a patient showing a severe bruise as a result of having a low platelet count, and you can just see that even just bumping into something causes a lot of bleeding underneath the skin, severe bruising, because the patient's got an inadequate amount of functioning platelets that are able to clot off that area. Vitamin K is necessary for the regulation of clotting, and it works in a couple different areas in the patient's clotting cascade. So having a vitamin K deficiency could lead the patients to having a problem with coagulation. Easy enough to fix, we give vitamin K. Vitamin K is also the drug that would be given to a patient who has taken too much warfarin. Warfarin is a type of anticoagulant. Liver disease can also cause the patient to have problems with coagulation, because coagulation and vitamin K synthesis is done in the liver. So we need to have adequate liver function in order to have adequate functioning of our clotting cascade. Hemophilia is a situation where the patient has a specific disorder that's causing them to bleed. So the patient has specific disorders here that are causing problems in our clotting cascade. So these are specific defects of the clotting cascade that the patient that the patient received in a hereditary manner. DIC, or disseminated intravascular coagulation, another way you might see this written is disseminated intravascular coagulopathy. What's happening in this situation here is the patient has an overwhelming, out of control inflammatory response going on in the vasculature, and inflammation is causing clotting to occur in the vessels where there shouldn't be clotting. So we get these widespread thromboses going on throughout the body. Clotting factors start to become consumed. The fibrolytic system becomes activated in order to break down these unnecessary clots that are being formed throughout the body. This can lead to bleeding. As it says, there's a high mortality rate associated with DIC. However, that's a high mortality rate associated with untreated DIC. Take a look at some of the situations that can cause a patient to develop DIC. So we can have OB situations like the patient has placenta previa, or some kind of situation where there's a significant amount of bleeding. And that's one of the things we probably ought to add to our list there, is just bleeding. When a patient's bleeding, they're losing lots of platelets, we're activating the clotting cascade, and then that can lead to the patient developing clots even away from the area where the bleeding is occurring. Infections, and especially sepsis, are going to be situations where DIC can form. Shock, trauma, and surgery are also situations. Whatever the case may be, we have an initiating factor, so it's one of those things, bleeding, trauma, etc., that's causing this inflammatory process to occur, which causes clotting. Now we're seeing the clotting forming, those little clots forming in that capillary network. Well, on the other side of the clot, the tissue's saying, hey, we're not getting any blood flow over here. We need to break down those clots. And it stimulates the fibrolytic pathway to break down those clots, and that causes bleeding. So this is kind of a confusing process where we have clotting occurring on one end, bleeding occurring on the other hand. How can you have both occurring at the same time? Well, it's a very complicated process here that occurs in DIC. One way maybe to conceptualize this that might make sense to you at this point is just to think about it like this. The clotting is occurring on the arterial side, the bleeding is occurring on the venous side. It's really not quite that simple, but it might help you to be able to conceptualize this in your head and kind of hold that in there and say, okay, I can get an idea as to how both things could happen at the same time. As a result of all this bleeding that's going on, we're using up platelets, we're having decreased perfusion, and those two things are going to cause the patient to have bleeding. So remember, there's two situations going on, clotting and bleeding. The bleeding part is going to be illustrated on the outside of the body very well by having bleeding, frank bleeding occurring from wounds and things like that. Also by having bruising, and we see lots of bruising occurring on this patient's body as a result of the patient having DIC. The thing we don't see is the clotting occurring inside the body, in the organs, and that's going to cause venous thromboemboli, myocardial infarctions, pulmonary embolus, CVAs, That's a cerebral vascular accident, otherwise known as a stroke. We can get ischemia, we can get organ dysfunction. So that's all the result of that internal clotting going on. And that's not something you see on the outside of the body, illustrated like this here, that grabs your attention saying, wow, I can see the bleeding, but I can't see the clotting. So if we think the patient's got DIC, we have to consider that both are going on. Now, diagnostically, we can look at a number of different things to tell us that our patient potentially is going to have DIC. We can look at our diagnostic tests like our platelets, our PT-PTT. So the platelet count's going to go down, right, because we're using up platelets in this process. PT-PTT is an indication of our patient's bleeding. These are literally their times. Their prothrombin time and partial thromboplastin time is what the initials stand for. And they're talking about the amount of time it takes for the patient's blood to clot. So obviously that's going to increase. Okay, if we're having bleeding, then the time it takes to clot is going to increase. Our fibrin degradation products, that's the breaking down of blood clots. So those are going to increase because we're breaking down more blood clots. D-dimer, you're going to see this again. And you're going to hear about D-dimer again. D-dimer is the first part of the fibrolytic pathway. So breaking down clots. So D-dimer will elevate because the fibrolytic pathway has been activated. Lastly, we're going to have our liver function tests. Those will also elevate because all this junk is getting stuck in the liver. Now, the reason why we don't see a lot of full-blown DIC, and the reason why we don't hear about lots and lots of people dying of DIC, is because usually we have identified the underlying disorder and we start replacing the blood products right away. So we treat the underlying disorder, we treat the shock, we stop the bleeding, we start replacing the blood products, and the patient never gets to that full-blown DIC. However, if we're unable to do that, then the process continues. The drug we're going to use here in order to try to stop the process is heparin. And heparin is a medication that's going to stop clotting. Okay, now again, if you're looking at all that bruising and if you're looking at all that bleeding on the outside of the patient's body, this may not make a lot of sense. But remember that the bleeding is occurring because of the bruising and because of the clotting that is occurring. So the bleeding is occurring because of the clotting. So if we stop the clotting, therefore, we'll stop the bleeding. All right, let's take a look at a case study here. Your neighbor cuts his hand with a razor blade, comes knocking at your door, bleeding. Okay, now be aware this stuff's going to start to happen. As soon as your friends find out, your neighbors find out that you're in nursing school, everybody's going to come to you for advice. All right, and as soon as you become a nurse, everybody comes to you for advice and says, "Hey, you're a nurse. Tell me how to do this, or do you think this is a hernia, or what? All sorts of embarrassing stuff people come up to you with." So your neighbor comes up to you knocking at the door bleeding. You tell him that the bleeding will stop in a few minutes, and he asks you why. So you explain the basic process of homeostasis. Now, one thing that may be very helpful here would be to put a little bit of direct pressure on the bleeding. Okay, let's help that homeostasis to start to occur. But, okay, so what is the process here that's going to occur that's going to cause the patient to develop homeostasis? So take some time to look over these questions, review this information in your book, and to answer these questions so that you can have a better idea of what is the process of homeostasis and what is the purpose of homeostasis. How can the clotting cascade be part of this and fibrolysis be part of this, and why are all of those components necessary in our patient's body? In your PowerPoint, there's a number of links that may be very helpful to you in your studies. Make sure you're using those links, looking at those videos and those additional animations, especially when it comes to the hematologic system. You may find those to be very helpful in helping you to study and to better conceptualize what the hematologic system is all about. Again, some of these concepts like hematology and cardiology might be easier to understand if you can get some visual representations. I would recommend that you look at the book Pathophysiology Made Incredibly Visual, It's one of those incredibly easy books. You can get it at the library. Our library has it. In addition, you could buy it at a bookstore at Amazon.com or something like that as well. All right, well, thanks for joining me for Structure and Function of the Hematologic System. This is David Woodruff, and until next time, bye now.